Hello, everyone. My name's Maria. I'm the FSEP Medical Student Council Chair. I'm here with Dr. Parsons from UF Jacksonville. So, Dr. Parsons, if you'd like to introduce yourself.
Hi, everyone. My name is Melissa Parsons. I'm the program director here at UF Jax. I've been in this role for a year and a half now, but I've been here at UF Jax since I was a fourth year med student. So I rotated here, fell in love with the program, came here for residency, stayed on as faculty initially in like a community role, and then transitioned back downtown doing a lot of our medical education work, and then stepped into the program director role uh, last September. So this is, I'm about to match my second class. So that's kind of how I am gauging how long I've been a PD. This is my second match class. But it's been a really fun experience to see the program change and develop over time, and to get to kind of use, so much of what we do in medicine is, I don't know, very analytical and like all these things. And so sometimes I think the medical education side of things is like using my creative side of my brain to see how we can take problems that are brought to me by the residents and find a way to fix them, improve them, make them better in some way, shape, or form. So I always say it's my creative outlet.
Yeah, no, for sure. I like that. And then, so I guess going off of, I know you're probably very busy now with this new PD role, but what has been the best trip that you've ever taken in your travels?
So I got married in Costa Rica, and so that was definitely my best trip of all times. And then I actually just got to go back last month as soon as I finished interview season. So that was a fun like sigh of relief. I got to surf a little bit, I got to fish a little bit. Those are I love fishing. That's actually my thing. So
Nice. One of my best friends like just started fishing a lot and she sends me the pictures of the fish and I'm like, the blue-green fish. It's really pretty. But no, that sounds like an awesome trip. It's nice that you got to go back after the wedding. So I guess moving on to your program, what are some key highlights of the clinical training that you guys offer, especially in the earlier years of residency?
sure. So we are a very county hospital. We have the University of Florida affiliated with us. So there's an academic component to it. Kind of the hidden gem of our program is we're actually in like the top EM programs as far as research funding dollars go around the country, but I would never describe us as like an academic site. We're county and we're very resident run. And so what I mean by that, because I really have to explain that a lot during interview season, is the residents touch almost every patient that comes through the doors of our emergency department on a daily basis. We have a fast track area where there may be APPs that are seeing patients separate from the residents, but it's very few patients. I, as the attending, am there to supervise the residents and to educate them. I'm not seeing patients on my own. I'm not seeing the sickest patients. You'll find me in the back of the room trying to like sit on my hands and not take over at times. But they really get that experience of moving patients through the department from day one of their residency training. So one of the things that I describe a lot is we have a low acuity and a high acuity area. And so the residents, as an intern, you get to work with our like least sick to our sickest patients. And that patient is yours. You own them, you do the procedures on them, all of those sorts of things. Our interns get all of the airways in our medical recesses. So we focus really on a lot of sick patient care as interns, a lot of critical procedures like intubations as interns. The only thing that they don't do as interns is they don't work in our resuscitation area on their own as interns. It's something you get to do as a second year and like kind of prove yourself, and then you do it for the rest of your career here. So yeah, it's a little bit different from some other places, but it's there's this progressive like graduated responsibility that each year you get something new added to your plate. And so that's, how I would describe our program, I guess. County, there's a little bit of academics in there. And then we actually do have a community hospital and 3 freestanding emergency departments. We're about to open a 4th one in the next year or so. I doubt that it's really open in the next year, but there were architects yesterday on my shift, so who knows? So our residents also get to see kind of a community hospital for a little bit of their training, but the majority of their training is going to be at our downtown county hospital.
Okay, nice. Yeah, no, I'm glad that you explained that because it's like, those are always things that people label programs as, so like county, academic, community, whatever. And it's like, wait, what does this mean? Like as a student, you're just like, teach me. But yeah.
I had no idea as a student. So I rotated at 3 different places and they happened to be UF Jax, which then I found out was county. And then I had like a very academic place and a very community hospital and was like, oh, I was made for a county hospital. But like if I hadn't had those experiences, I don't know that I would have recognized that as easily. So yes, if you like our rotators will find this is their county experience, and then they can see other places that may be very different from us to get a gauge of what fits them, what suits them, and where they learn best. Because if you asked me, I never would have told you as a med student that like I learned by getting my hands dirty and doing. I would have been like, no, please help me and teach me and show me how to do everything. And then I found I was the exact opposite of what I thought.
Yeah, for sure. And no, so I know you just touched on it a little bit, like regarding the interns and stuff, but how does the residency responsibility progress? Like, what are like the PGY3s doing?
Sure. So our PGY2s become the COD, which stands for Chief of the Day. Our surgery service likes to joke that we're the cod and the salmon, but that's not true. So our second years become the COD in flex care, which is our lower acuity area. And that's where they really start to get a feel for, they have to kind of run that area. So I always like to joke with them. They start like taking sign outs at the end of their first year and they feel really good in like May, June about I'm taking sign outs, I'm acting like the cod, I know what I'm doing. And then July happens and they have a brand new intern who has like 1 or 2 patients out of the 14 beds that are there. And they're like, oh, this is really hard. Right. So there's this jump that they go through at the beginning of their year from having like somebody who they were splitting an entire area with to now they're really running it. And so that's kind of becomes their graduated responsibility. They start to look at the waiting room and how do we get the sickest patients back and kind of move, departmental flow. And then third year, you become the COD in ECC, which is our high acuity area. And that COD goes to all the recesses, all of the traumas in our emergency department. They also supervise the intern. So the ECC intern is we assign patients orange, blue in that area. The way second or third year and an intern will get assigned patients at the same rate, which we all know is not right. Like an intern shouldn't be able to keep up with the second or third year. So there's a third year paired with them to help them and kind of help keep them afloat, guide them, put orders in for them, see their patients with them, and keep them moving so that they kind of learn under a little bit more pressure. And then the third year supervises any off-service residents as well. So that's really where, they're making decisions about, do I page this out as a stroke alert? Should this be a resus? Looking at interns patients and off-service interns patients, kind of like you would supervise an APP in a community setting. And they really get to feel kind of the flow. I know, it's flu season right now, admit holds are kind of everywhere. But so they're learning about that whole admit, now we have a bunch of admit holds. Where do we put them? Who can we move safely? How do we do that? So there's a lot of educational value to that. When I went out into the community for my first job, I was very comfortable with rearranging deck chairs on the Titanic is like the joke that I've always had about it. Cause the shift is going down no matter what, it's only going to get worse. There's not less patients coming. And so, trying to keep the sickest patients in front of you and move patients that are safer to move to other areas, that sort of thing.
Yeah, for sure. It's really interesting that you mentioned that because I think that when you go into residency, you think like, oh yeah, I'm gonna take care of patients and like that's it. But I think that how your program does okay, we should manage how to get people in and stuff like that is important to learn as a resident because when you're an attending, you're the one that's going to be in charge of that. So it is cool that you guys add that as a resident responsibility so they can learn how to do that once they're an attending and be ready for it.
Yep.
Very So
The other thing I would say, our second years do a month of resuscitation. So that's taking care of all of our traumas that come in and all of our like level 1 patients. So EMS can request a resus bed. It's all of our STEMIs, all of our strokes, anybody who needs like respiratory support or may need to be intubated, those sorts of things. So they take care of all of those patients. And then once you have that month, then you get those shifts longitudinally over time. And then, well, what was I going to say? I don't know. So second and third years have that, which is something that's a little bit different that we do. And those are by far the best shifts. If you asked me as an attending what shift I want, it's always a resus shift.
yeah, for sure. So then going off of that, the curriculum itself, how do you guys balance the curriculum of like all this hands-on learning that you're doing with the didactic education?
Sure. So we have didactics are Thursday mornings for us. We do 5 hours of didactics. It is protected time. So faculty work Thursday to protect the residents. That's when I would take recess shifts. But now that I'm program director, I'm supposed to be at conference and I don't get my shifts anymore. But yeah, so that's when the residents have the majority of their didactic time. We do have journal club. Actually, tonight is our journal club. So we do journal club a little bit off. It's in the evening. It's not necessarily protected, but we invite residents, their families. Typically we have, food, drink, other things. So that's not exactly part of didactic, but another component of it. We do a lot of sim. We're very sim heavy. And so if we have 4 weeks in a month, 2 of those, half of the time is spent in sim. So we're doing 5 hours of sim every month, maybe more, depending on whether or not we do a sim M&M case. So a lot of sim time because most of us like getting our hands dirty, and then foundations, cases, small group learnings, didactics, kind of all mixed together.
Nice. It sounds like a good mix to get them all of the like educational, stuff on the side.
Yeah,
Um,
we try to get out of our seats as much as possible.
yeah, for sure. Yeah, I get antsy. It's like we need to move around.
Yeah.
But so going off of the curriculum too, how much elective time is built in? I know you were talking earlier about some of the off-service stuff. So
Mhm.
how flexible is the program for residents to be able to explore other specialties within the field?
Sure. So we don't have tracks per se, but a lot of times our residents who want to take a more academic route and go into a fellowship or something after the fact, a lot of times they kind of declare themselves very early in residency and it's easy for them. Technically, we have 1 elective block. That being said, my residents who are going into a fellowship, the other block is like a community and a community ED block that at times we will morph into other things depending on what they need for their fellowship. So like sometimes sports med fellowships, they'll need a letter of rec from somebody and they may need to go like do an away, like almost like an away elective. And so we've adjusted schedules in the past if people are looking for a fellowship. But like that being said, ultrasound people, they start ultrasound from the very beginning. And so they will, get involved in SAM, sono games, all the ultrasound competitions, we had something at FSEP recently where there was ultrasound stuff. So our residents who want to be involved in ultrasound have gotten to be involved in those sorts of ways, and have kind of set a path that's what they're doing from the beginning. We have such a breadth of faculty that have so many interests that we, as soon as the resident says, "Oh, Parsons, I'm interested in XYZ," it's like, okay, great, let's connect you with this person who's doing this and go. And then for my residents who really just are here to go into community medicine, they do that too. And so I would say in the past, we've normally had like 1 to 2 people go into academics and fellowships, which is part of why we don't have we haven't like mandated fellowship tracks. Not this year, but last year, 7 out of my 15 went to fellowship. But that was a very strange year of, right after some harsh matches, where I think we really pushed people towards fellowship. And then this year, I think I have three going into fellowships and then another one going into academics. So it's pretty spread out. And so it's very much driven by what the resident wants and what they're looking for. And then we can make it happen.
Yeah, for sure. I mean, like it does, it's, it shows like you don't have to have the mandated, tracks, but you guys are so willing to help out and get them connected. So I think that's what anyone should really, look for. So then as a like PD, what do you look for in a successful resident at your program, or what do they look at?
Sure. Are you asking like when they're already here or when during recruitment time?
Like when they're already there, like what is
Okay.
like a successful resident look like to you?
Yeah. So I tell people basically as residents and before they're residents here, my two big things are going to be work ethic and do you want to take care of the patients that we take care of. So we serve a very underserved patient population, an inner city county patient population. They don't have a lot of other places to go for access to care, for resources. And sometimes that requires us to put in extra time, right? If you're discharging me from the hospital, I'm a physician. I have pretty good medical understanding, right? It should be pretty easy to discharge me. I can get resources. I have health insurance. I can get my meds filled, right? But some of our patients aren't going to have any of those things. And you really have to work with them to understand, what's keeping them from being able, right? They may have insurance, but they may not have the money to pay the copay for that script. And how can we meet them where they're at? And so that does take a little bit of, sometimes a lot of bit of extra work on the resident's part. And you really have to care about, wanting to help this patient population. And so those are normally my two big things. I mean, from a work ethic standpoint, it's not just, going an extra mile for a specific patient, but I think our department like really runs based on the residents, right? I'm not seeing all the patients and moving the department. So I need residents that are driven to want to work hard, to move patients, to provide excellent care for them, but also get them through and keep going. When I just got done working a shift, and I think that the people who want to be here and want to do the work, they bring an energy that's infectious and it's fun. Like it's fun to be in the department. People are joking, people are laughing, and there's just this higher energy. And so it's kind of a self-fulfilling prophecy, right? I want people who want to be here because that makes it easier to train them. But it also makes it a lot more fun to be on shift together. And we really have developed a family over the last decade. I think that's the biggest change I've seen in the residency since I was a resident. And so it's always the thing I'm the most proud of is watching the residents kind of support one another, get each other through the program. We all know residency is not the easiest time of our lives, shall we say. But yeah.
Yeah, it's always good. I was a scribe in the ED and I would like, when it's like your favorite team and you're all working together, you're so excited, like, oh, this is like no matter what comes in the door, you're like so excited to be there. So it makes the time like, oh wait, we're done, like so I agree. It's definitely nice to have that environment. So speaking of environment, what do you guys do to promote wellness in your program?
Sure. So this is such an interesting question to me as a PD because I think we all kind of think of wellness a little bit differently. And so one of the things my residents have said is like, we don't want you organizing like yoga classes for us. And I was like, cool, I don't need to organize a yoga class for you. We actually did it at one point before I was in charge. And we had a resident pass out doing yoga in conference. So that's embarrassing. And that was the end of that. But we try to do things to continue to build that camaraderie between the residents because, truthfully, they're your best support system during residency. While we all may have spouses, significant other families, other things, it is hard for a lot of those people to understand what we're going through. I know there's the pit is out now and everybody is having their spouse or significant other watch the pit to know what our lives are like. But I think that really building that camaraderie is one of the things we've put a lot of emphasis on. So we have class day offs. Actually, my PGY2 class just had their class day off yesterday together and they went down to St. Augustine together. And so trying to schedule them together. One of the things I realized was like after orientation, the next day that you have off together as a class is graduation. And so trying to make it more common that all of our class or as many people as possible can be off together at a time to do something is probably has been my biggest and most challenging endeavor all at the same time. And then we try to do some fun, I don't want to say activities, but we do a community service event every year. It used to be a kickball event and we've moved towards pickleball, and I'm waiting to hear what the residents want to do this year. Because pickleball was such a hit that I think it's going to stay. And the
Yeah.
residents are really just competing to see who can beat me at pickleball right now. I love that. Taking down the PD is obviously the most important thing in our residency at the moment. And then right now we have a fitness challenge going, trying to encourage the residents to, stay moving, stay healthy, even when this is kind of the hardest time of the year. I think the days are short, you work long hours. So we have a top male and a top female, the award that will be given out shortly. So they're competing with faculty too. So the faculty get to push them, but the residents will win. I think that's a majority of the things. But we have a wellness committee of residents who come and they bring ideas and what I should do next and what things we should work on. So I try to let the residents run it, because me lecturing on wellness or dictating how we provide wellness is probably not the best way to do it.
No, I think that's great. Like it sounds like it's a lot of like fun little things and they all add like the pickleball thing, that's so fun. I but yeah, no, it sounds really good. Sounds like they all really enjoy it. So then going as students that are watching this video one day, how can applicants stand out or what do you look for with students that will do audition rotations with you guys?
Yeah, so we love having audition rotators. Honestly, it's probably half of my match class almost every year. And I think once people see us, they figure out like, oh, I want to be there. This is a great place for me, or this is absolutely not for me. And we want both of those, right? Like I want people who want to be here and are going to be happy here. So, I think the audition rotation is really seeing what fits, seeing if this is a good fit for you, more so than it honestly is seeing if it's a good fit for us. What would I tell a med student rotating with us? I think it's really about like, yes, there's a component of being like on your best behavior because it's an audition rotation, right? But it's a lot of it is just like being a good human. You don't have to know everything. We don't expect you to know everything. You're here to learn, right? But trying to find ways to help. It's very different. So when I was a med student, we had like paper charts. I know I'm showing my age at this point, right? But like you could basically circle all the things on the chart for the resident. The med student role is much less of being able to care for the patient. But seeing students like go back and trying to talk to patients and get a little bit more information or better clarification, trying to hone their presentation skills. I think we learn to present as med students, like really as like an internal medicine presentation of like all of the things. And so a lot of times the feedback first rotation students get is like, yeah, sure, tighten that up a little bit. Maybe we don't need to know like their 5 last bowel movements. Just maybe that like they've had one in the last day would be great. Those sorts of things. So, being able to take that feedback and trying to apply it in some way, but like nobody's going to expect you to be perfect. And one of the weird things about the emergency department is for students and residents, like you're going to work with a different attending or a different senior resident every day. And we all have different preferences. We all do things differently. And so like one of the things I always tell people is like, you're going to leave here with like a little me on your shoulder, but like you're also going to have a little Dr. Caro and a little Dr. Morrissey and like a little Dr. Godwin and all these people. And you're going to hear all of our feedback's in your head when you go to take care of a patient, and like you're going to pick which ones you listen to at different times. And I think for the students, that's so important to understand, like, you may get feedback that's different because people do things different ways, and don't internalize that. Just keep trying to figure out how you can tweak your practice a little bit at a time. Um, and then, yeah, while you're here specifically, it's very much about fit, and figuring out whether this is a fit for you. And do you want to look at other county programs? Are you like, oh no, that was way too much. I really want, you know, not such a crazy place. Great. Like, that's a learning process. It's not a waste of a rotation. You're going to learn something. You're going to get a slow, it's more about figuring out what's a good fit.
Yeah, for sure. I really like that. So then before we end, what's one final message that you want people to take away from your program?
Hmm. Ooh, I think the one thing I tell people a lot, right, is we are we're old. So this is actually 2025 is our 50th anniversary of being an emergency medicine residency program. We're one of the oldest, like first 25 in maybe we're the 25th in the country. I don't know. We're old. But I think the fun part about doing this job as a PD, and I think my residents would tell you too, is like we're continually trying to change things and adapt. Um, it's funny that I've said this forever, and now we just got our new ACGME requirements, and there'll be a lot of adaptation that's coming our way, as I have found out recently. But I think we really try to adapt based on resident feedback and continue to build this place to be the best that it can be. And our learners are changing over time, right? The learners I'm teaching today are very different than how I was as a learner, and trying to continue adapting so that we can meet our learners where they're at is the thing that I am the most proud of, but also it's like why I love this job, right? If we just kept doing what we had done 20 years ago, I don't know why we need a PD. We would just have all the paperwork and be done with it. So for me, that's kind of the fun part, and getting the residents involved, and getting their opinion on things. They know I'll come on and be like, I have an idea, and they're like, oh no, Parsons, we're all in trouble. So yeah, we may be old, but we are constantly changing, growing, and adapting. And I think that's kind of the fun thing about this place.
Sounds great. Well, thank you so much for taking the time to speak with us today. I'm sure that all the students watching this video will really enjoy it and, take a lot of information from you guys. So thanks again.
Thank you so much.